Okay, bladder, trigone, and the neck of the bladder. These are mainly located postsynaptically. Okay, these are mainly postsynaptic receptors. So alpha 2 mainly located in the presynaptic nerve terminals of cholinergic as well as adrenergic neuron, also present in the platelets, okay, also located in the beta cells of pancreas, okay, where it inhibits the release of insulin. Okay, and one more important point you have to remember is these alpha 2 receptor which are located presynaptically are known as R2 receptors. Okay, what is the function of these autoreceptors? You have to remember. See, this is the presynaptic neuron. Okay, this is the effector organ. So this is the alpha 2 receptors, which is the autoreceptor. What is the function of this autoreceptor? Whenever you stimulate this alpha 2 receptor, which inhibits the release of neurotransmitter. Okay, stimulation of this presynaptic alpha 2 receptor, which is autoreceptor, decreases the release of neurotransmitter. How it decreases? It decreases by inhibiting the efflux of calcium. Influx of calcium, we know, because any release of neurotransmitters requires the influx of calcium. Then only, for example, if the acetylcholine is stored in the synaptic vesicle, it releases whenever the calcium influx takes place through the process of exocytosis. So by inhibiting the calcium influx, it inhibits the release of neurotransmitter and also by causing the hyperpolarization. Okay, this is by two important mechanisms. These presynaptic autoreceptors inhibits the release of neurotransmitters by causing the hyperpolarization as well as by inhibiting the calcium influx in the presynaptic neuron. So stimulation of this decreases the neurotransmitter release. So if you block this receptor, what happens? There will be increased release of neurotransmitter. That is a very, very important point. Is a reverse of normal receptor. Stimulation of autoreceptor, especially alpha 2, decreases the neurotransmitter release. Blockade of presynaptic autoreceptor increases the release of neurotransmitter. Please remember that part is very, very important. Beta 1 receptors are located in the heart and juxtaglomerular cells of the kidney. Beta 2 mainly located in the bronchial smooth muscles, blood vessels, liver, uterus, and also in the dextrosor muscle of the urinary bladder. Beta 3 also located in the adipose tissue and the bladder, dextrosor muscle of the bladder, which is the location of alpha and beta receptors are very, very, very important because based on this location only most of the questions are asked. Okay, okay, this is just beta 1 located in the heart and beta 2 located in the lungs, just to remember. Okay, now we'll see what are the actions of sympathetic nervous system. So these alpha 1 receptors are located in the radial muscles of the iris. Okay, these radial muscles are supplied by the sympathetic nervous system. Okay, the stimulation of this radial muscle of the iris causes the mydriasis, the contraction of radial muscles through the alpha 1 receptor, which produces mydriasis. We call it as active mydriasis. Okay, in the lungs, we know the beta 2 receptors are located in the lungs, the stimulation of which produces the bronchodilation. And also the blood vessels of the nasopharynx, okay, the mucosa consists of alpha 1 receptor, which produces vasoconstriction of the blood vessels of the mucosa along with the beta 2 mediated bronchodilation, which increases the lumen diameter of the lungs, okay, which increases the airway. So that the bronchodilation, see, beta 2 mediated bronchodilation happens in the lungs by the action of sympathetic nervous system, which is contributed by the alpha 1 mediated the constriction of the mucus of the bronchus, so which increases the luminal diameter of the bronchus, so which produces the bronchodilation effect. So on heart, what happens? By stimulating the beta 1 receptors, it increases the heart rate, okay, it increases the conduction velocity, okay, that means it has got positive inotropic, positive chronotropic, and positive dromotropic effect. Increases the heart rate, increases the contraction, and increases the conduction velocity of the heart takes place by the stimulation of beta 1 receptor. In blood vessels, there is a presence of both alpha 1 and beta 2 receptors. As stimulation of alpha 1 receptors causes vasoconstriction. Very, very important point. Please remember this. Stimulation of alpha 1 receptor produces vasoconstriction. and stimulation of beta 2 receptor produces vasodilatation. So what happens whenever the stimulation of sympathetic system on the blood vessels? It is depending upon the predominant or the dominance of that receptor. The sympathetic system produces the effect on the blood vessel. For example, if the blood vessels, the alpha 1 receptor dominance is there. For example, the alpha 1 receptors numbers are more than the beta 2. So that blood vessels undergo vasoconstriction. The blood vessels has more number of beta 2 receptor than alpha 1. That blood vessels go into vasodilatation. Remember, alpha 1 means vasoconstriction, beta 2 means vasodilatation. In GAT, what happens? There will be beta 2 mediated relaxant effects on the intestine, and also as well as there will be presence of presynaptic alpha 2 receptors. See, this is the presynaptic neuron. This is the cholinergic neuron. Okay, this is the cholinergic neuron which contains alpha 2 receptor. Okay, in cholinergic neuron, we know acetylcholine is the neurotransmitter. Okay, this is the adrenergic neuron. Okay, the noradrenaline which released in the adrenergic neuron stimulates the alpha 2 receptor. We know what is the function of alpha 2 receptors. What happens whenever the presynaptic alpha 2 receptors are stimulated? What happens when you stimulate the presynaptic alpha 2 receptors and the neurotransmitter release? It decreases the release of neurotransmitter. Okay, so neurotransmitter release is decreases here, so which decreases the peristalsis movement of the intestine. That's why, and the GAT, the presence of presynaptic alpha 2 receptor produces relaxant effect on the intestine along with the beta 2 mediated relaxant effect. Okay, in the bladder, what happens? There will be urinary retention because the detrusor muscles of the bladder. Okay, this is the detrusor muscle which can made up of beta 2 and beta 3. Okay, and this is the trigone which consists of alpha 1 receptor. This is the urethra. It is also made up of alpha 1 receptor. So relaxation of beta 2 and beta 3 and the constriction of the bladder trigone and the sphincter of the urethra causes the urinary retention. Very, very important. What happens on the uterus? The pregnant uterus, there will be predominant of beta 2 receptors on the pregnant uterus which produces relaxation, whereas in the non-pregnant uterus there will be alpha receptors are more which produces the contraction of the uterus. So what happens on the genital system? Okay, alpha 1 receptors are located in the vas deferens and seminal vesicle and prostate, stimulation of which produces or facilitates the ejaculation. Very, very important. So what are the metabolic actions of sympathetic system? So the beta 3 receptors we know mainly located in the adipose tissues. So there will be increased lipase enzyme. So there will be increased breakdown of triglyceride into fatty acid. So what happens in the liver? Liver consists of beta 2 receptors. There will be increased glucose production in the form of gluconeogenesis and glycogenolysis. In the heart, again, there will be beta 2 mediated glycogenolysis and gluconeogenesis. Okay, this is the metabolic action on the heart. What happens on the alpha 2? I told alpha 2 receptors are located in the pancreatic beta cells. Stimulation of those alpha 2 receptors decreases the insulin secretion. So all this, the metabolic action causes hyperglycemia. Okay, the sympathetic stimulation causes hyperglycemia because of all these actions. Okay, we'll see some of the drugs which acts on the sympathetic system. We classify into directly acting sympathomimetics, indirectly acting sympathomimetics, and mixed action. Directly acting sympathomimetics means these drugs directly stimulate the alpha and beta receptors. Indirectly acting sympathomimetics means this drug increases the release of the catecholamines. Catecholamines is nothing but the noradrenaline, adrenaline, and dopamine. So by increasing the release of the catecholamines, these drugs acts on the alpha and beta receptors. The drugs like theramine and amphetamine are the indirectly acting sympathomimetics. Mixed action, that means they directly stimulate the alpha and beta receptors as well as they increase the release of neurotransmitters, that is the catecholamines. Okay, we call it as mixed action. For example, ephedrine, dopamine, norepinephrine. The directly acting sympathomimetics are mainly These are the endogenous catecholamines like adrenaline, noradrenaline, isoprenaline, whereas phenylephrine, methoxamine, citalopram, and the salmeterol, these are the synthetic catecholamines. So this is very, very important. Based on this, most of the MCQ are asked from it is at the action of adrenaline. Adrenaline mainly acts on the alpha 1, alpha 2, beta 1, beta 2. It has got weak beta 3 action. That means adrenaline acts on all the adrenaline receptor except beta 3. Noradrenaline acts on alpha 1, alpha 2, beta 1, beta 3. No beta 2 action. Very, very important. Remember, noradrenaline has got doesn't have beta 2 action. Isoprenaline, it has got no alpha action. It only acts on the beta receptors, that is beta 1, beta 2, beta 3. This is very, very important. You have to remember this at any cost. Okay, adrenaline, all the receptor except beta 3. Noradrenaline is no beta 2 action. Isoprenaline, no alpha action. It's very important. Based on this, I will give some of the important points for you to remember. Systolic blood pressure is mainly determined by the cardiac output, which in turn depends on the beta 1 receptor action. Okay, that means whenever the beta 1 receptor is stimulated, there will be increased systolic BP. The diastolic BP is mainly determined by the status of blood vessels. The status of blood vessel in turn depends on the presence of alpha 1 and beta 2 receptors. We know alpha 1 receptor stimulation, vasoconstriction, beta 2 receptor stimulation, vasodilatation. That means stimulation of alpha 1 receptors produces vasoconstriction, which increases the diastolic BP. Beta 2 stimulation, we know it produces vasodilatation. Vasodilatation results in decrease in diastolic BP. Very, very important. Alpha 1 stimulation increases the diastolic BP. Beta 2 stimulation decreases the diastolic BP. Beta 1 stimulation increases the systolic BP. So what happens when there is an increase or decrease the diastolic BP? That is very, very important for the reflex mechanism. So what happens whenever there is a increased diastolic BP? There will be baroreceptor mediated vagal action. Okay, so there will what happens? See, whenever the increased diastolic BP stimulate the baroreceptors. Okay, the baroreceptors are located mainly in the carotid sinus as well as in the arch of the aorta. Okay, these are nothing but the pressure sensors. So whenever the increased diastolic BP, these pressure sensors are activated, okay, which in turn activates the vagus nerve. So vagus nerve, we know it's a inhibitory nerve, so which acts on the heart M2 receptors. Okay, so what happens? There is a stimulation of M2 receptors on the heart. It produces bradycardia, so decreased heart rate. Okay, whenever there is a increased diastolic BP, the baroreceptors are activated, which in turn stimulates the vagus nerve. The vagus nerves release the acetylcholine, which acts on the M2 receptors, the heart, which decreases the heart rate. We call it as bradycardia. This is very, very important point. So what happens whenever there is a decreased diastolic blood pressure? So there will be increased central sympathetic outflow. There is increased release of catecholamine in the brain. Okay, that increases the heart rate. These are the very, very two important compensatory mechanism you have to remember. Okay, for the solving the MCQs. Very, very important. Okay, so this table I want you to uh, carefully listen and remember. So action of adrenaline, noradrenaline, isoprenaline on the systolic blood pressure, diastolic blood pressure, as well as on the heart rate. So we know adrenaline acts on the beta 1 receptors, so systolic BP increases. So this adrenaline, whenever you give slow IV infusion, so it reduces the diastolic blood pressure. If you give rapid IV infusion, it increases the diastolic blood pressure. So that means it has got action on both the alpha and beta receptors. So there will be nil effect on the diastolic blood pressure. So as a result, there is no reflex action on the heart. So the heart rate increases. Okay, adrenaline produces increase in systolic blood pressure, increase in the heart. So there is, because of the nil effect on the diastolic BP, the reflex action will not be there. So the net effect on the heart is heart rate increases. So what happened to mean blood pressure? There will be slight increase in the mean blood pressure. And what happens to peripheral vascular resistance? There will be, because of the alpha action, there will be slight increase in the peripheral resistance. So what is the action of noradrenaline on the systolic BP? We know noradrenaline acts on the beta 1 receptor. So obviously it increases the systolic BP. Okay, it has got no beta 2 action. So they acts the alpha 1 receptor. We know alpha 1 receptor increases the diastolic BP. There will be marked increase in diastolic BP. Whenever the diastolic BP increases, we know the baroreceptors are stimulated, so which in turn activates the vagus nerve, which inhibits the heart via M2 receptors. We know. So the net effect on the heart will be bradycardia, that is decreased heart rate. So this is very, very important. So what happens to mean BP? So there will be slight increase in the mean BP because of the alpha action. So there will be increase in the peripheral resistance because of alpha action. Okay, there is no beta 2, so there will be vasoconstriction of the peripheral blood vessels that increase the peripheral vascular resistance, and also the mean BP increases. Very good. What happens to isoprenaline? Isoprenaline has got no alpha action. So acts on the beta 1, increases the systolic BP. Okay, no alpha action. So there will be predominant beta 2. So that decreases the diastolic BP. We know whenever the diastolic BP decreases, there will be stimulation of central sympathetic outflow. There will be increased central sympathetic outflow that increases the heart rate. Okay, this is very, very important. So what happens here, because of there is no alpha action, the mean blood pressure decreases significantly, and also the peripheral vascular resistance decreases significantly because of no alpha action. This table you have to remember at any cost, because they are asking MCQs mostly on this table. Because if you remember the action of the adrenaline, noradrenaline, and isoprenaline on different receptors, you can remember this table, very, very important. So we'll solve some MCQs based on this. Okay, we'll move on to next. Adrenaline. So adrenaline, we know it's a drug of choice for the anaphylactic shock. The dose is about 0.3 to 0.5 ml. Has to be in the dilution of 1:1000. Has to be given intramuscularly on the vastus lateralis and the thigh. Okay, the lateral part of the thigh and the vastus lateralis. If the intramuscular injection is not working, then it can be given IV in the dilution of 1:10,000. Okay, one is to, you have to increase the dilution. If you want to give IV, if IM is not producing any effect, this already dilution is 1:10,000. Okay, what are the other use of adrenaline? It can be used to combine with the local anesthetic. It is a potent vasoconstrictor agent. When you combine with the local anesthetic, it increases the duration of action of local anesthetic, and by reducing the systemic absorption, it reduces the systemic toxicity, and also because of the vasoconstrictor agent, it provides the bloodless field for surgery. That is the uses of combination of adrenaline with local anesthetic. One important clinically, you have to remember that this adrenaline mixed with local anesthetic should not be injected in the places where there is end arteries. For example, in the fingers, okay, tip of the nose, ear pinna, and in the genitals, where there will be presence of end arteries. If you give the local anesthetic which mixed with adrenaline, that results in gangrene. So in these areas where there is a presence of end arteries, we have to give the plain lignocaine. Okay, that means there will be no mix. Plain lignocaine means which does not have any adrenaline. Okay, that plain lignocaine has to be given in the places where there are end arteries, because of the action of the vasoconstrictor action of adrenaline. It produces gangrene in those places. So adrenaline can also be used to stimulate the heart in case of cardiac arrest due to electrocution or drowning. Okay, in those conditions, the preferred route is intravenous, and the dilution is 1:10,000, which is very, very important. These are some of the uses of adrenaline. Dopamine. This is very, very important. The dose-dependent action of dopamine. This is a table from the Harrison. The dopamine, whenever you give in the dose of 1 to 2 microgram per kg per minute, remember this dose 1 to 2 microgram, 2 to 10 microgram, 10 to 20 or more than 10 microgram per kg per minute. At the dose of 1 to 2 microgram, it acts on the D1 receptors. So D1 receptors are mainly located in the blood vessels of the kidney, renal blood vessels. Whenever the stimulation of D1 receptors, it produces renal vasodilatation. Okay, renal vasodilatation. So which increases the renal blood flow, improves the GFR. Very, very important. At the dose of 1 to 2 microgram per kg per minute, dopamine stimulates the D1 receptors of the renal blood vessels, increase the renal blood flow, increases the GFR. At the dose of 2 to 10 microgram per kg minute, it stimulates the beta 1 receptors of the heart. Whenever the beta 1 receptors of the heart are stimulated, it has got positive inotropic and positive chronotropic effect, and also it increases the BP. Okay, stimulates the heart as well as increase the BP at the dose of 2 to 10 microgram per kg per minute, acts on beta 1 receptor. At the dose of 10 to 20 microgram or more than 10 microgram per kg per minute, it produces stimulates the alpha 1 receptor, which results in generalized vasoconstriction. Very, very important. 1 to 2 microgram per kg stimulates the D1 receptors, which produces renal vasodilatation. 2 to 10 microgram per kg stimulates the beta 1 receptor of the heart, positive inotropic, increases BP. More than 10 microgram per kg per minute stimulates the alpha 1 receptor, which produces generalized vasoconstriction. So, because of this, the beta 1 receptors mediated action as well as increase in BP and also increase the renal blood flow is a drug of choice for the cardiogenic shock. Okay, cardiogenic shock in patient with renal failure. Okay, it's a drug of choice in patient with cardiogenic shock with renal failure. The drug is the dopamine. It's very, very important. The dose is 2 to 10 microgram per kg per minute. Very, very. Okay, what are the other drugs belongs to the sympathomimetics? The pressure agents like phenylephrine, methoxamine, dopamine, mephedrine. This ephedrine is the vasopressor of choice in pregnancy. Okay, because these are the methoxamine, mephedrine. These are the vasopressor agent mainly used in treatment of hypotension during the general anesthesia or during surgery. This acts on alpha 1 receptor, okay, increases the blood pressure. So if it's given to pregnant women in case of hypotension, that decreases it causes fetal hypoxia by decreasing the vitroplacental perfusion. So this ephedrine has got additional beta 2 action which do not produces fetal hypoxia. So ephedrine is the drug of choice, vasopressor of choice in pregnancy. So this methoxamine and mephedrine used in the treatment of orthostatic hypotension or hypotension during the anesthesia or surgery. So the phenylephrine is mainly we use as a mydriatic as well as in the nasal drops. Cardiac stimulant we know used in the treatment of cardiogenic shock as well as the anaphylactic shock. Bronchodilators mainly by action on beta 2 receptors, they produces bronchodilation used in the treatment of asthma and COPD. This nasal congestant, oxymetazoline, cialometazoline and naproxeline, this acts on the alpha 1 receptor, produces the decongestion of the nasal mucosa. So what happens? There will be in the cold, there will be vasodilatation of the nasal blood vessels. There will be congestion. So by blocking the alpha 1 receptor, it produces vasoconstriction, which relieves the nasal stuffiness and nasal congestion. If you use this drug for a long period of time, this nasal decongestant produces atropic rhinitis. For a long period of application, produces atropic rhinitis as well as anosmia. That is two important side effects of this nasal decongestant. CNS stimulants like amphetamine, mephedrine, dexamphetamine used in the treatment of attention deficit hyperkinetic disorder because these drugs, because of the CNS stimulant action, increases the concentration, okay, increases the learning ability, increases the attention spasm, okay, and increasing the reticular activity, stimulating the reticular activity system, it postpones the sleep. Okay, because of this, it can be used in treatment of attention deficit hyperkinetic disorder. Because long-term stimulation also produces a lot of side effects because it causes the postponement of the sleep. The patient will be agitated, there will be tremors. Okay, so it is not suitable for the students. Okay, because some students want to take it during the exam because it postpones the sleep, but following which it produces a lot of discomfort. So it is better to be avoided, but it can be used in the treatment of attention deficit hyperkinetic disorder in the children who has got a slow learning ability, the slow concentration, okay, reduced concentration, reduced attention span, which is increased by giving the CNS stimulants like amphetamine. One important side effects of this amphetamine in children, it produces growth retardation because it inhibits the hypothalamus feeding center, suppresses the appetite, as a result of which the children won't feel like eating food, that results in the growth retardation. It is one important side effect of this amphetamine. Anorectics, mainly these are used to Nowadays, we are not used these are the banned drugs because they increase the cardiovascular mortality. In the initial days, they are used to reduce the weight in some gym centers and all. Because it increases the cardiovascular mortality, these drugs are banned, called anorectics. Uterine relaxants, drugs like ritodrine and the isosexaprine, mainly used in the premature labor. Okay, to prevent the uterine contraction in premature labor. This drug produces uterine relaxation used in the premature labor. These are some of the use of sympathomimetic drugs. So we see now the antagonist, adrenoreceptor antagonist. We classify into alpha blocker as well as beta blocker. Alpha blocker, we have got phenoxybenzamine non-selective. That means it acts on the alpha 1, alpha 2. The drug like phenoxybenzamine, phentolamine, non-selective alpha blocker. This phenoxybenzamine is a irreversible antagonist. Irreversible antagonist of alpha receptor because it binds to alpha receptor by covalent bond. So phenoxybenzamine is a irreversible competitive antagonist of alpha receptors. Alpha 1 selective, these drugs are mainly used in the treatment of benign prostatic hyperplasia. We'll discuss that later. And these are the beta blockers. We'll see detail in the next line. So one more important concept we need to understand here, vasomotor reversal of Dale. This is first given by, identified by the Sir Henry Dale. Okay, what happens? He demonstrated the effect of catecholamines on the blood pressure. So with the help of adrenaline, so what happens whenever you identify the effect of catecholamines on the blood pressure. So this is the blood, when you do a recording of the blood pressure, when you give the adrenaline normally, we know it acts on the alpha 1 receptors as well as beta 2 receptors. These alpha 1 receptors are less sensitive. That means they need higher dose of the adrenaline to stimulate the alpha receptors. Sorry. Okay, we need higher dose of adrenaline to limit the alpha 1 receptor, where the beta 2 receptors are very, very sensitive. That means even the small doses of adrenaline can stimulate the beta 2 receptors. So on recording the blood pressure, whenever you give the adrenaline by acting on the alpha receptor, what it should produce? Okay, it produces response like this. It produces the increased blood pressure because of the alpha 1 action, decrease the blood pressure by beta 2 action. That means when you give the high dose of adrenaline, because we know alpha receptors are the strong receptors, they need higher dose of adrenaline to stimulate the alpha receptor. So it acts on the alpha 1 receptor, produces the increased BP. So when after producing the increased BP, because of the vasoconstrictive effect of alpha 1 receptors, the adrenaline get metabolized and only small amount of adrenaline will be remaining that acts on the beta 2 receptor. We know beta 2 receptors are very sensitive for the even the low dose of adrenaline that produces decrease in the BP. So this response we call it as biphasic response of adrenaline. Okay, it's a biphasic response. So what is vasomotor reversal of Dale? That means for the action of this adrenaline, that is increased BP followed by the decreased BP, when you give the alpha blocker here, okay, when you give alpha blocker at this point, then you give adrenaline. So it produces what? It produces only a decrease in BP because that amount of adrenaline which now acting on the beta 2 receptor, which is highly sensitive, it produces a decrease in blood pressure more than normal. So that effect we call it as vasomotor reversal of Dale. That means administration of adrenaline, high doses of adrenaline following the alpha blocker, only the decreased BP is seen, which is due to beta mediated vasodilatation. We call it as vasomotor reversal of Dale. That means when you give the alpha blocker, then you give high doses of the adrenaline. So because alpha receptors are blocked, so it is not producing increased BP. Now only beta receptors are present. It acts on the beta receptor, it produces the vasodilatation. That means the biphasic response will be not there after the administration of alpha blocker. We call it as vasomotor reversal of Dale. Very, very important. So what is the importance of this? It's very, very important you have to know in the treatment of pheochromocytoma. Clinical importance. Pheochromocytoma, we know it is the tumor of adrenal medulla. Okay, the tumor of adrenal medulla secretes the large amount of catecholamines. Because of that, there will be high increase in the BP. We call it as hypertensive crisis. Okay, the tumor of adrenal medulla secretes two types of catecholamines, that is adrenaline as well as noradrenaline. Adrenaline producing tumor as well as noradrenaline producing tumor. So what happens? We use in the pheochromocytoma, we use drug like alpha blocker. Mainly, we use alpha blocker like phenoxybenzamine and phentolamine are the alpha blocker used in the treatment of pheochromocytoma to prevent this hypertensive crisis. Here, whenever you there will be released large amount of adrenaline because in clinically we will not give high amount of adrenaline because it has got lot of arrhythmogenic action. High amount of adrenaline is not given clinically, but this tumor is releasing the large amount of adrenaline. So the treatment you give alpha blocker. So what happens normally? This is the response produced by the adrenaline. Okay, when you give alpha blocker here, the adrenaline which acts on the beta receptors, which produces more prolonged decrease in BP because there will be large amount of adrenaline. That much reduce in BP, it produces what? Hypotension. Produces hypotension. The patient may go into shock. Okay, so that's why in the treatment of the adrenaline producing tumor of alpha plus beta blocker. Okay, we have to give alpha plus beta blocker. Okay, so you have to give the beta blocker also to prevent the hypotension and shock. Whereas in noradrenaline producing tumor, we know noradrenaline has got nothing to do with the beta 2 receptors. So we use only alpha blocker in the treatment of the noradrenaline producing tumor of pheochromocytoma. Okay, whereas in adrenaline producing tumor, the combination of alpha and beta blocker should be used, whereas in the noradrenaline only alpha blocker is sufficient. It's very, very important. So here in adrenaline producing tumor, if you give only beta blocker, what happens? If we give only beta blocker, the adrenaline which acts on the alpha receptor only and produces marked increase in BP that can produce the stroke. That's why the combination should be given. If you give only alpha blocker, there will be marked reduction of BP which produces shock. If you give only beta blocker, there will be increased BP which produces stroke. So that's why the combination should be used in the treatment of adrenaline producing the tumors of adrenal medulla in pheochromocytoma. The beta blockers most commonly used are phenoxybenzamine and phentolamine. Very, very important. You have to remember this point. Okay, now we'll see what are the selective alpha 1 blockers. So these are the selective alpha 1 blockers like prazosin, doxazosin, alphazosin, tamsulosin, and silodosin. Very, very important. This prazosin, it's a non-selective alpha 1 receptor blocker. So it is mainly these drugs are mainly used in the treatment of benign prostatic hyperplasia. By blocking the alpha 1 receptor, we know alpha 1 receptors are located in the neck of the bladder and the sphincter. So if you remove the vasoconstriction effect, so there will be widening of urine. That is the main problem in the benign prostatic hyperplasia because there will be urinary retention will be there. So if you relax the bladder, trigone, and the urethra, sphincters as well as prostate, the widening of urine takes place that produces beneficial effect in the benign prostatic hyperplasia. So by blocking the alpha 1 receptor, it helps in the micturition in case of benign prostatic hyperplasia. So because it is got non-selective alpha blocker, then this prazosin produces the postural hypotension. Because when you block the alpha receptors, there will be beta-mediated vasodilation, there will be peripheral pooling of the blood, decreased venous return. The person is standing, he develop the postural hypertension, will become dizzy and he will faint. So that is the first dose phenomena is most commonly seen in the non-selective alpha blockers like prazosin. Okay, so these are the prazosin is the main drug which produces the postural hypertension. We call it as the first dose phenomena. So how you reduce the first dose phenomena with the prazosin? We just give with the start with the low dose and usually give at the bedtime. By doing this, we can prevent the first dose phenomena or the postural hypertension which is produced by the prazosin. Very, very. This terazosin and doxazosin, they have got apoptotic promoting effect. So they retard the progression of hyperplasia of the prostate. Okay, this is prazosin is short acting. These are long acting. The T of is here. Prazosin is 12 hours, whereas doxazosin is 18 hours. So single daily administration is sufficient. And in addition, they got apoptosis promoting effect, which delays the progression of benign prostatic hyperplasia as an added advantage in prazosin and doxazosin. So this postural hypotension is more commonly with all these three drugs. Okay, because they mainly act on alpha 1A as well as alpha 1B. Whereas this tamsulosin and silodosin, they mainly act on alpha 1A receptor. Okay, alpha 1A receptor. So it is devoid of the postural hypertension or first dose phenomena. The tamsulosin, silodosin does not produce the postural hypertension or first dose phenomena where because it blocks only alpha 1A, whereas these two drugs blocks the both alpha 1A and alpha 1B. And prazosin is also produces one important side effect, that is impotence. We know alpha 1 receptors located in the seminal vesicle vas deferens, which causes ejaculation. So by blocking the alpha 1 receptors, there will be inhibition of ejaculation that results in impotence. So this impotence and postural hypertension are the first dose phenomena, are the most common important side effects of prazosin, tazocin, and doxycycline because they block both the alpha 1A and alpha 1B. Whereas tamsulosin produces blocks only alpha 1A receptors, so it is devoid of impotence as well as first dose phenomena. In turn, these two drugs produces retrograde ejaculation. That is one important side effect of tamsulosin and silodosin. And one more important side effect is intraoperative floppy iris syndrome. This most commonly seen with the tamsulosin. This tamsulosin produces intraoperative floppy iris syndrome. What does it mean? Because we know alpha 1A receptors also located in the radial muscles of the iris. Whenever the alpha 1 receptor of the radial muscle of the iris are blocked, the radial muscle of the iris undergo flaccid paralysis. It becomes flaccid. So during the cataract surgery, if you want to remove the lens, the iris will prolapse at the site of extraction. If you want to remove the cataract from this point, so this iris will prolapse because it's flaccid and it's paralyzed. So there will be prolapse of the iris because of the blockade of alpha 1 receptor on the radial muscles, which is caused by tamsulosin. It produces intraoperative floppy iris syndrome during the cataract extraction. That is during the extraction of the cataract or cataract surgery, the prolapse of the iris is seen in case of tamsulosin. That is the one important side effects of tamsulosin. Very, very important. Okay, this is a diagram just to show that alpha 1A receptors are located in the bladder trigone. Okay, this is the prostatic urethra. Okay, so by blocking these alpha 1A receptors, so there will be relaxation of this trigone and the prostatic urethra. There will be widening of urine. So okay, that's how it produces beneficial effect in the benign prostatic hyperplasia. Because whenever the alpha 1 receptors are stimulated, it contracts the trigone as well as the sphincter urethra. So the widening become difficult. By blocking the alpha 1 receptors, which are present in the neck of the bladder, trigone, and the prostatic urethra, so this will be relaxed. So there will be widening of the urine that produces beneficial effect in the benign prostatic hyperplasia. Usually, these alpha blockers are combined with the 5-alpha reductase inhibitors for the treatment of benign prostatic hyperplasia. This is very good. Now we'll see the word beta blockers. Beta blockers are classified into first generation, second generation, and third generation. Okay, some of these beta blockers has got additional properties. For example, this pindolol, acebutolol, and the celiprolol. They got intrinsic sympathomimetic activity. What does it mean? Along with blocking the beta receptors, it got partial agonistic activity on the beta 1 receptors also. Means main action is blocking the beta receptors. At the same time, it has got partial agonistic activity on the beta 1 receptor. We call it as intrinsic sympathomimetic activity, pindolol, acebutolol, and celiprolol. Very important. This sotalol has got the potassium blocking effect, additional potassium channel, the cardiac rectifier potassium channel blocking effect. So it is a can be used as class 3 anti-arrhythmic drugs. Okay, these are the cardioselective beta blockers. It acts only on the beta 1 receptor present in the heart. That's called cardioselective beta blockers. This esmolol is ultra short acting beta blocker. The T off is less than 10 minutes. Okay, it is inactivated by the esterases in the plasma. So it is half-life is less than 10 minutes. It's the ultra short-acting beta blocker, mainly used in the treatment of paroxysmal supraventricular tachycardia, atrial fibrillation, atrial filter. We have to give the IV infusion of this esmolol. Very, very important. This labetalol and carvedilol, they got additional alpha blocking action. Very, very important. You have to remember these are the additional effects of beta blockers. They are asking you this. Okay. This nebuvolol and celiprolol, they increase the nitric oxide synthase in the endothelium of the blood vessels, which releases the nitric oxide, has got additional vasodilatation effect. Okay. Nebuvolol and the celiprolol, they release the nitric oxide, okay, and delay the progress of atherosclerosis. Because of this, has got releases the nitric oxide, has got vasodilatation effect. Nebuvolol and the celiprolol. This bitoxolol mainly used, it's devoid of, mainly used in treatment of glaucoma in the form of eye drops. Okay, bitoxolol mainly used in treatment of glaucoma as a eye drops. These are very, very important. The classification of beta blockers with additional effect. This propranolol, okay, oxprenolol, and again acebutolol, they got additional sodium channel blocking property. So we got a membrane stabilizing property. Okay, it can also used in the treatment of arrhythmias, and it has got additional corneal. It produces corneal anesthesia, irritation, and corneal anesthesia. Okay, by blocking the sodium channel, additional sodium channel blocking property. It is used in treatment of arrhythmias, and also it produces corneal anesthesia. This timolol is devoid of corneal anesthesia effect. So it is used as an eye drop in the treatment of glaucoma. So these are the important points you have to remember with the beta blockers. So what are the limitations of non-selective beta blockers? That means it block both alpha, beta 1 and beta 2 irrespective, because non-selective, it can act on both beta 1, beta 2. As a result of receptors, it produces bronchoconstriction, so it is contraindicated in bronchial asthma. So it marks the warning sign of hypoglycemia. What happens in diabetic patients who are on insulin? So they frequently undergo hypoglycemia. Okay, so there will be decreased blood sugar level. Because of the decreased blood glucose level in blood, there will be stimulation of sympathetic system. Okay, sympathetic system produces what? Tachycardia, tremors. Okay, these are the warning signs of hypoglycemia. That means whenever the diabetic patients who are taking the insulin, whenever the blood glucose comes down, there will be stimulation of sympathetic nervous system that produces tachycardia and tremors. That gives a sign to the patient that is your blood glucose is low, take some sugar now. That's why you must have seen most of the patients, they are keeping the chocolates in their pocket. So whenever they feel that palpitations, that tremors, okay, and sweating, okay, that is the indication that your blood glucose is low, to take the glucose immediately. So that is the reason during that time, whenever this warning symptoms appears, if you take some sugar, some take chocolate, and take some juice, your blood glucose will come to normal. That prevents the patient going into hypoglycemic coma. But if you give beta blockers, these warning signs of hypoglycemia like tachycardia and tremors will be blocked, will not be there. Okay, and the patient will go into hypoglycemic coma. Okay, the sweating is not blocked. Why? Because the sweating is sympathetic cholinergic. Sympathetic cholinergic, we know the sweat glands mainly innervated by the sympathetic nervous system, sympathetic neurons, but the neurotransmitter released is acetylcholine and the receptors present are M3. The sympathetic cholinergic, so sweating is not affected. Only patient will have sweating. The sweating due to any other reasons, it cannot be taken as a warning sign. The main warning sign like tachycardia and tremors, which are mainly due to beta 2 mediated action, that will be blocked by the beta blockers, the patient will go into hypoglycemic coma. So that is the disadvantage of non-selective beta blockers. It worsens the peripheral vascular disease. By blocking the beta 2 receptors, there will be increased alpha 1 mediated vasoconstriction that causes worsening of peripheral vascular disease. Impairs the beta exercise capacity. The beta 2 receptors will be present in the blood vessels of skeletal muscle or the exercise muscle. So whenever the beta 2 receptors are stimulated, vasodilatation, there will be increased blood flow to the skeletal muscles. So there will be increased exercising capacity. By blocking the beta 2 receptors, the blood flow to the skeletal muscle will be decreased. So there will be impaired exercise capacity. So these are the disadvantage, or you can take it as a side effects of the beta blockers. So advantage of cardioselective beta blockers. Because we know it cardiospectrum means it acts only on beta 1, which is located in the heart. So it does not produce the bronchoconstriction, can be safely given in asthmatic. It does not inhibits the warning signs of hypoglycemia, can be given in the diabetics. It does not produce the alpha mediated vasoconstriction, so it can be safely given in the peripheral vascular dissipation. And it does not block the beta 2 receptors. There is no reduction of blood flow to the skeletal muscle, so it does not impair the exercise capacity. These are the advantages of cardiospectrum beta blockers. Very important. Now, what are the uses of these beta blockers? It is used in the treatment of mild to moderate compensated heart failure. Remember, it is contraindicated because it has got inhibitory effect on the heart. It causes worsening of the heart failure. The beta blockers are contraindicated in the acute decompensated heart failure. So where it can be used? It can be used in the treatment of only mild to moderate compensated heart failure. Okay, that is the one important use. In angina, it is used only in the classical angina. In angina, we know there will be imbalance between the myocardial oxygen supply and demand. By reducing the workload on the heart, by reducing the cardiac work, it reduces the myocardial oxygen demand. That is used only in the treatment of classical angina. Okay, in classical angina, what happens? There will be atherosclerotic narrowing of the coronary artery. Because of that, there will be ischemia and pain. So it is used only in the treatment of classical angina. It is contraindicated in the Prince metal or the variant angina. In Prince metal or variant angina, what happens? Because of the increased sympathetic activity, there will be coronary vasospasm. If there is already coronary vasospasm, if we give the beta blockers, there will be additional alpha mediated vasoconstriction that causes worsening of the variant angina. That is the reason these beta blockers are contraindicated in the Prince metal or the variant angina or vasospastic angina. Is indicated only in treatment of classical angina. Very. Reduce in the treatment of hypertension by decreasing the workload on the heart, by decreasing the contraction of the heart rate, cardiac output. It reduces the BP, and also by inhibiting the beta receptor of the juxtaglomerular cells of the kidney, reduces the release of the angiotensin, which is a potent vasoconstrictor, reduces the BP again. Myocardial infarction and the long-term treatment, it prevents the reinfarction, prevents the ventricular fibrillation during the myocardial infarction, and during the evolving the myocardial infarction, it prevents the reinfarction as well as it prevents the enlargement of the clot. That is very important. Like drugs like esmolol used in treatment of cardiac arrhythmia, especially supraventricular tachycardia, atrial fibrillation can be used treatment. Again, dissecting aortic aneurysm by decreasing the heart rate and BP, it produces beneficial effect in the dissecting aortic aneurysm. We will discuss in detail when we check the read about the cardiovascular system. Now we just superficial remember. Hypertrophic obstructive cardiomyopathy, there will be subaortic region of the endocardium will be thick. Okay, that causes the outflow obstruction. So these beta blockers reduces the outflow obstruction and improves the and decreases the heart rate. That's why it is used in HOCM. Migraine, beta blockers are most commonly, these are all beta 1 mediated. By blocking the beta 1 receptors, it produces all this effect. This is by blocking the beta 2 receptors. Migraine, it most commonly nowadays used propranolol. Propranolol mainly used as a migraine prophylaxis, produces beneficial effect in migraine. Anxiety and essential tremor, all peripherally mediated beta 2 receptor mediated. By blocking the beta 2 receptors, it suppresses the anxiety and essential tremor. For example, some people will having the stage fear because of the sympathetic discharge, sympathetic activity, which stimulates the beta 2 receptors on the skeletal muscle, produces tremors and anxiety. So if you take the propranolol 10 milligram, so this anxiety and tremors will just go off. So the stage fear will go. So that is due to treatment, but it does not inhibit the tremors of Parkinsonism. Okay, that is due to different action. There will be alcohol withdrawal, there will be increased sympathetic activity. To block that increased sympathetic activity, like withdrawal symptoms, like tremors, agitations, can be prevented by giving the beta blockers. Hyperthyroidism. In hyperthyroidism, what happens? There will be increased sympathetic activity, there will be increased upregulation of the beta 1 receptors, which produces tachycardia, palpitation, which can be blocked by beta receptors. In glaucoma, by decreasing the aqueous humor production, can be used in treatment of glaucoma. We'll discuss in detail. Pheochromocytoma, I told. Glaucoma, you know, it's a disorder which causes the progressive damage of the optic nerve will be there. Why? Because there will be increased intraocular tension, more than 21 millimeter of mercury. Because of that increased intraocular tension, there will be damage to optic nerve. What is the result of this intraocular tension? It could be either increased production of the aqueous humor, or decreased drainage of aqueous humor. In both the conditions, there will be increased intraocular tension, which damages the optic nerve. We call the condition as glaucoma. So, for to understand this, this is the ciliary body. From here, will be secretion of aqueous humor. This is the posterior chamber. From the posterior chamber, it enters the anterior chamber. It undergoes two important drainage systems. One is the trabecular outflow. Okay, this is we call it as the trabecular outflow, which is drains into the Schlems canal. This is the Schlems canal. This is the trabecular. This is dot is the trabecular meshwork. Okay, most of the 90% of the drainage takes place through the trabecular meshwork. We call it as trabecular outflow, and remaining 10% will be drained into the connective tissues of the ciliary muscle. Okay, we call it as uveoscleral outflow. This is the trabecular outflow. Okay, and remaining 10% will go into the connective tissue spaces of the ciliary muscle, and ultimately both they drain into the episcleral vein. Okay, there are two important drainage systems. One is trabecular outflow. Okay, same thing. I just see trabecular meshwork through the slum canal and into the episcleral vein. This is about almost 90%. Okay, some textbooks says 90. Okay, and uveoscleral outflow, it is only 10%. Okay, it enters into the ciliary body. We call it as uveoscleral outflow. So what happens in glaucoma? This is the closed angle glaucoma. So whenever there is a mydriasis, this iris comes in contact with the lens and obstruct the iridocorneal angle. Whenever the iridocorneal angle is blocked, so there will be obstruction of drainage to aqueous humor that increases the intraocular tension, which produces glaucoma in closed angle glaucoma. Okay, in open angle glaucoma, what happens? This is the open angle glaucoma. See, the iridocorneal angle is open, but the trabecular meshwork loses the patency. The patency of the trabecular meshwork will be lost, so that the draining facility will be obstructed. So there will be no drainage, as a result of which, even though the iridocorneal angle is open, because the patency of the trabecular meshwork is lost, there will be decreased drainage of the aqueous humor. Again, it produces the increased intraocular tension. Okay, so now we'll see the drugs. Okay, so this is the ciliary. The picture shows the ciliary body or ciliary muscle. So the ciliary muscle is made up of the blood vessels, which consist of alpha 1 receptor. Okay, and the ciliary epithelium, which consists of alpha 2 receptors, beta 2 receptor, and carbonic anhydrase enzyme. Okay, so we know in glaucoma there will be increased production of aqueous humor or decreased drainage of the aqueous humor. Why this increased production of aqueous humor takes place? Because of the increased blood flow, which is due to vasodilatation. Okay, because of the increased blood flow, there will be vasodilatation that increases the production of aqueous humor. So we know the ciliary body consists of alpha receptors as well as beta receptor. If you stimulate the alpha receptor, there will be vasoconstriction. Okay, if you block the beta receptor, again there will be vasoconstriction. Because of vasoconstriction, what happens? There will be decreased blood flow. So there will be decreased production of aqueous humor. So that means to say that in the treatment of glaucoma, we have to give the alpha agonist and the beta blockers. Alpha agonist and beta blockers are mainly used in the treatment of glaucoma, which acts by mainly decreasing the production of aqueous humor. Very, very important. Okay, this day I just made everything in a simple diagram. We know alpha agonist and beta blockers, by acting on the blood vessels of the ciliary body, they decreases the aqueous humor secretion. Okay, that is a mechanism. So alpha agonist, the drug like we have got apraconidine and the brimonidine. Very, very important. This brimonidine produces respiratory depression and apnea in neonates. The brimonidine produces respiratory depression and apnea in neonates. This apraconidine, it produces lid retraction. These are the side effects of this alpha agonist. Okay, apraconidine produces lid retraction, whereas brimonidine produces respiratory depression and apnea in neonates. Remember, beta blockers. Beta blockers, drugs like timolol, cartilol, and levodopa, they, by blocking the beta receptor on the blood vessel, decrease the aqueous humor secretion, because we know beta blockers Yeah, they causes exacerbation of asthma and COPD. So for that reason, we can give betoxolol, which is beta 1 receptor blocker, so that the asthma and COPD and not be there with betoxolol. So initially, the clinician starts with the betoxolol, then they move on to the timolol. Okay, that is very, very important. But betoxolol is not that effective because we know the beta 2 receptors are located in the ciliary body. So the beta 1 receptor does not produce that much beneficial effect, but it is devoid of the other side effects like asthma, COPD, and bradycardia. It is the preferred drug. Prostaglandin analog like latanoprost, bimatoprost, and travoprost. Okay, what does it do? They increases the permeability of the ciliary muscle and the episcleral veins. Increases the permeability of the ciliary muscles and the episcleral veins, so it increases the uveoscleral outflow. Very, very important side effect produced by the prostaglandin analog is increased growth of the eyelashes. We call it as hypertrichosis. It causes, and also it causes iris pigmentation, permanent iris pigmentation, hypertrichosis, increased growth of the eyelashes, and macular edema. These are three important side effects produced by the prostaglandin analog: hypertrichosis, iris pigmentation, as well as macular edema by prostaglandin analog. Carbonic anhydrase inhibitors, okay, like dorzolamide, brinzolamide, and acetazolamide. So they decreases the bicarbonate secretion in the aqueous humor, thereby decrease the aqueous humor formation. Okay, here acetazolamide is given as a oral tablet